the end result, the end winner to any such debate should be our patient. It's neither Manav nor me. That's my starting point. And I'll be talking against prescribing these medications by hepatologists. But the result is not going to be this slide. So we've all heard about these three metabolic disorders: diabetes, type 2 diabetes, MASLD, and obesity. They have a common site of origin. They have a common pathophysiological defects leading to these diseases, and their treatments are very similar. So whenever we talk about such debates, we're talking about managing metabolic diseases, not one part of it. It's the entire patient we take care of. So let's keep that in mind. Now, why this debate? It's very clear. We heard in the last talks, the drugs, how the newer anti-diabetic drugs have become safer as far as lesser chances of hypoglycemia, extra glycemic benefits, and here we're talking about liver health, be it histology, be it liver enzymes, be it the MRI, be it the liver fat. These drugs have showed repeatedly benefits going beyond just glycemic control. And two of the studies done here on SGLT2 inhibitors and the GLP-1 RAs have actually come from our center at Medanta. So these were the first studies in which we took obese diabetic patients, those who had type 2 diabetes, and showed their benefits in their liver parameters, and that's where the whole story started. And that's why we're having this debate, who's going to prescribe these drugs. To me, the GLP-1 RAs and SGLT2 inhibitors provide an umbrella of health for these three metabolic disorders, not just the direct effects on liver health. They provide a metabolic benefit addressing the pathophysiological defects, which is the common soil from where all of these diseases originate. And we've heard about their cardiovascular benefits happening. Also, a lot of indirect benefits which may contribute to the better liver health with these drugs. These include weight loss, benefits on blood pressure, reduction in the pro-inflammatory cytokines, two very exciting benefits of semaglutide. One is cigarette cessation and abstinence from alcohol. A lot of our patients, them and their families are very happy. They just don't feel like having alcohol. And the two most important unaddressed risk factors in cardiovascular medicine is smoking and alcohol. So this one-stop shop of a GLP-1 is addressing their metabolic functions, their weight loss, their blood pressure, pro-inflammatory markers, and contributing to cigarette cessation and limiting alcohol intake. So that's the package, why we need to give these drugs in our patients. Well, if we really need to stake claim on this drug, we need to start with the two basic pillars of managing any metabolic disease, which is nutrition and fitness. So we need to agree on the fact that all of our patients must be provided with these two pillars before we go on to expensive medications. And especially in our country where everything comes out of the pocket, we all know about affordability of these newer medications, which are pretty expensive. Do I have an objection of Manav prescribing these drugs? Now comes the surprise. No, I don't. I agree with him prescribing these drugs. However, the court of law says that he needs to agree to these terms and conditions, which I'm going to present in the next 3 slides. Very simple terms and conditions. You know this from your MBBS days, your MD, your DM, and you do it, and you understand that, and on the podium, we discuss these. But if Manav assures me he's going to do all of these, we accept it, and we're going to be a larger, happier family. So this promise is already there, and let's see how we can go by that. Managing diabetes and MASLD together, the basic principles, why do we treat it? Well, very simple, is to prevent complications or the downstream effects of these 3 metabolic disorders. The UKPDS 91 told us early intensive glycemic control, principle number 1. The day the patient lands up with us, be it with a MASLD, be it with obesity or with type 2 diabetes. Start early, be aggressive. That's how you're going to create the best metabolic memory and a legacy of prevention of complications. We all agree on that, right? Start early, identify obesity. If there's one area I would really like to invest on, is on weight management and obesity, where these drugs perform exceedingly well, with the GLP-1 RAs already been approved in non-diabetics for weight loss and all the metabolic benefits. So start early. Steno 2 trial told, if you really want to save lives by treating diabetes, you need to have a multi-pronged approach where it should be nutrition, it should be fitness, it should be weight loss, glycemic control, blood pressure control, cholesterol control, statins, ACE inhibitors, ARBs, aspirin, cigarette cessation, limitation of alcohol. Once you do that, you complete the list, and then we can say, yes, I'm going to provide you good cardiovascular health, good liver health, good all health, and good mental health. And that's what has happened, the revolution beyond glycemic control. These are the latest American Diabetes Association guidelines, which no more, you don't see the HbA1c. We talk about organs, organ protection, high-risk population in deciding which drugs we need to prescribe to a particular patient. And for the first time, 15% of this colored graph talks about weight loss. How come suddenly weight loss has appeared in this graph? Well, we've got effective pharmacotherapy, and that's exactly what Manav and me are debating about, who should use this. And the algorithm, again, mandatory for Manav to follow this, treat to target. It is not just giving a diabetic medication, it is getting them to the targets. So what are the targets? It's very simple, A, B, C, D, and O. A is A1C, B, blood pressure, C, cholesterol, D is using drugs with organ protection, and O is obesity or bariatric management. However, you need to get them to target to optimize the results. Tell me one study of complication prevention which said without these things, you can prevent the outcomes of a certain disease or disorder. None of them. These are the pillars of diabetes care. Again, mandatory to follow all of them before you write diabetes medications. I won't go in the details of this. In case there's a tiebreaker in between Manav and me, these two slides are meant for that. You could just take photographs of this. We could reflect back on these slides and discuss them in case we still haven't decided who's won. So these are the questions I may ask him in case need be. These are simple out-of-the-clinic questions. There's no rocket science in them. But you must know these things before you prescribe the medications. Approval, its indications, off-label use, you need to be sure you protect yourself, the right indications. To me, what is more important is places where you don't use a drug. It could be absolute, it could be relative, it could be based on the last 3 years of my experience in using a certain drug. I believe that these are the patients I would like to refrain from using these drugs. And this will come with experience. And Manav rightly said, there has to be some time where you start using the drug. Otherwise, you're never going to get the feel of a particular drug. Safety screening. So can we, just with a drop of a hat, prescribe these medications? No. There is a certain basic bare minimum we need to address before we start these medications. Their doses, their dose titration, method of administration, monitoring, and these are expensive medications. If you expect somebody to buy these medications out of their pocket, be ready to answer their issues or problems when they have side effects. And GLP-1 RAs, in our context, in our country, the side effect profile may be a little more different than in the West. So be ready for these things. And once you satisfy all of these, be my guest, we have such a large population who needs people like all of us. You go ahead and prescribe these drugs. So the last couple of slides is what I really desire to be happening, not a debate like this, is that all of us under one roof run a metabolic disease clinic. And I thank all of you for your kind listening. And this is how the world is going to look like when Manav and me take care of it. Thank you very much.